Fetal monitoring during labor was introduced in the 1960s, primarily to prevent intrapartum fetal death and secondarily to reduce neurologic injury due to hypoxia through early identification of abnormal fetal heart rate patterns. Since its widespread adoption, intrapartum fetal deaths have dramatically declined. However, despite this success, the rates of neonatal brain injury have remained essentially unchanged. One of the main challenges is the interpretation of fetal heart rate patterns. Interpretation is limited by high inter and intra-observer variability, and current approaches emphasize static cross-sectional assessment. As a result, most tracings are classified as indeterminate, which provides limited guidance for clinical management and contributes to both unnecessary interventions and missed opportunities for early recognition of evolving hypoxia. This is where new approaches may offer promise. Machine learning provides an objective approach to evaluating the entire intrapartum tracing. By examining longitudinal changes in fetal heart rate patterns rather than static classifications, machine learning may improve our ability to identify fetuses at risk for neurologic injury. The purpose of this study was to address the limitations of fetal heart rate interpretation by using a machine learning model to analyze the entire intrapartum tracing. This approach allowed for objective assessment of both the longitudinal changes and the duration of fetal heart rate patterns throughout labor. Specifically, we sought to determine whether this method could identify neonates with metabolic acidemia who required therapeutic hypothermia after birth, representing those at highest risk for neurologic injury. We further hypothesized that the duration of abnormal fetal heart rate tracings, rather than the pattern type alone, would play a critical role in predicting risk. This was a retrospective case control study conducted at a single academic institution. We identified neonates admitted to the neonatal intensive care unit with concerns for neonatal encephalopathy due to hypoxia ischemia between 2017 and 2023. The study group included neonates that qualified for therapeutic hypothermia based on clinical, biochemical, and neurologic criteria. Clinical criteria included gestational age greater than or equal to 35 weeks, birth weight of greater than or equal to 1,800 grams, and age less than 6 hours after birth. Biochemical criteria included umbilical or neonatal arterial pH less than or equal to 7.0 or base deficit of greater than or equal to 16 millimoles per liter within the first hour of life. If pH was 7.01 to 7.15 or base deficit 10 to 15.9 millimoles per liter, the neonates must have had intrapartum late or variable decelerations and one of the following: 5-minute APGAR less than 7, 10-minute APGAR less than 5, or assisted ventilation initiated at birth and continued for at least 10 minutes. Neurologic criteria included evidence of moderate to severe encephalopathy on the modified SARNA exam. The control group consisted of neonates who met the same clinical and biochemical criteria but did not demonstrate evidence of neonatal encephalopathy on neurologic examination and therefore did not undergo therapeutic hypothermia. Neonates with acute sentinel events such as placental abruption, cord prolapse, or uterine rupture, as well as those with congenital abnormalities, were excluded from the study. Complete intrapartum fetal heart rate tracings for the entire labor course were extracted and analyzed using a machine learning sliding window approach. The tracings were initially divided into 10-minute windows, and the window size was then increased in 5-minute increments until model performance metrics, including accuracy, precision, recall, and specificity, reached at least 99%. Each reading window was then analyzed using a 2-step machine learning process and labeled as either normal or abnormal. The primary outcome was the proportion of fetal heart rate windows labeled as abnormal throughout the entire intrapartum course for each fetus, which was then compared between study and control groups. A total of 44 mother-infant pairs were included in the final analysis, with 22 assigned to the study group and 22 to the control group. Maternal demographics, pregnancy complications, and neonatal demographics were similar between groups. The duration of intrapartum fetal heart rate tracings analyzed were also comparable. Despite these similarities, neonatal outcomes differed significantly between groups. The study group had lower APGAR scores at 1, 5, and 10 minutes, and encephalopathy and SARNA examination was far more common. Seizures occurred only in the study group, along with higher initial liver enzyme levels and longer hospital stays. Importantly, there were no significant differences between groups in umbilical cord pH, base deficit, or the need for respiratory support or chest compressions. To determine the optimal window size for analysis, a sliding window approach was applied, increasing the reading frame in 5-minute increments. As the window size increased, model performance steadily improved across all metrics. At a 90-minute window size, accuracy, precision, recall, and specificity each reached at least 99%. Increasing the window size beyond 90 minutes did not result in additional improvement, so 90 minutes was selected as the optimal window size for analysis. Using the optimal 90-minute window size, the model was then applied to all the intrapartum fetal heart rate tracings. The study group had an average of 73% of windows labeled abnormal. By contrast, the control group had only about 5% of windows labeled abnormal. This difference was highly significant with a p-value of less than 0.001. Importantly, there was complete separation between groups. Every neonate in the study group had more than 47% abnormal windows, while every neonate in the control group had fewer than 12%. In conclusion, a higher proportion of time spent with abnormal fetal heart rate patterns was strongly associated with neonates who required therapeutic hypothermia. This supports that the duration of exposure to abnormal patterns is a key driver of neurologic injury risk. Importantly, traditional perinatal clinical characteristics did not improve prediction beyond the information contained within the fetal heart rate tracing itself. By leveraging continuous and objective analysis of the entire intrapartum tracing, this model has the potential to improve the detection of evolving fetal compromise and enhance the accuracy of fetal heart rate interpretation. These patterns have several important implications. First, they underscore that the duration of the abnormal fetal heart rate patterns should be prioritized in risk assessment rather than focusing solely on the pattern type. Second, a machine learning-based approach has the potential to reduce subjectivity in interpretation and minimize false positive diagnoses that lead to unnecessary operative deliveries. At the same time, earlier and more accurate identification of evolving compromise may support more timely intervention to prevent neurologic injury. Finally, while these results are promising, prospective validation is needed before such a tool can be confidently integrated into clinical care. This work represents an important step toward objective intrapartum decision-making.